As healthcare realizes that improved outcomes and reduced costs are associated with processes that decrease variability, more workflows will be introduced. I want to speak briefly about 3 ways to think about complexity in workflow development, specifically around electronic medical records. This ties very closely into a previous presentation, if you Google it, entitled EHR Design from First Principles. And on that part, I discuss a user interface which involves a left workspace for viewing information and a right workspace for an action panel. And you can imagine customizing that action panel based on whatever workflow you are in. But this is a general concept that you can apply broadly within automated healthcare systems. And so the examples here when I speak about workflow will simply be a questionnaire being delivered in a clinic. But you can take the concept of workflow and really build it out as detailed as you want to imagine. So let's start into imagining the first of these 3 layers here, which is separate workflows. So separate workflow is the typical way which we operate on paper. One user will fill out a paper questionnaire, and then another user will fill out their own questionnaire. You could imagine a nurse completing a pre-clinic questionnaire that is then reviewed by the physician, or a pharmacist reviewing a medication education session with the patient, documenting it on their form, and then the clinic nurse reviewing the form later and filling out their own. The other thing to realize in this case is that the second clinician is always filling out information that is having to be repeated from past sources. These 2 workflows are independent and don't connect. And that's, for the most part, the way that paper-based systems operate, and that many electronic medical record systems that are a bit boring operate. We now move into level 2. So level 2 is simple task shifting, where one workflow can be divided among multiple users. So in this case, we still have a clinic questionnaire, just like in level 1, but information from the first user can flow into the second user's chart, which can then flow into the third user's chart. And so you could imagine a patient coming into the hypertension clinic, being seen by the nurse. That information goes into the physician questionnaire, and then that information goes into the pharmacist questionnaire. Very smooth. And so the other consideration to realize is that I am including inside of level 2 the ability for a user's workflow to rely on information found in the historic electronic medical record. So although I'm speaking previously about collecting information directly from the previous user, this could have been information that was actually entered weeks, months, or years before and is archived in a good format so that we can easily call those concepts into the required forms and pre-populate data. There are difficulties, more on an administrative level, on how to deal with information as we feed it forward through multiple users. And I'll discuss that in the footnotes after this presentation. And it's important to also realize that one of these players can actually be the patient themselves. They can answer questionnaires, their family members can answer questionnaires, they can collect longitudinal symptoms and generate patient-generated data. So that's level 2. We move now into level 3. And in level 3, what we have happening is dynamic task shifting. So we still have one single workflow, but the difference is that the workflow adapts and is allocated based on the environment. So for instance, if we had a clinic where you had a workflow involving parts A, B, C, and D, if, let's say, only the physician was in that clinic, the physician would have to then complete parts A, C, and D. In this example, part B is something the physician never would complete, even if no one else is in the clinic. But if we added a nurse to the clinic and there was a nurse and physician, then the nurse would complete parts A and D, and the physician would complete part C. If we also had a community health volunteer in that clinic on Mondays, then the community health volunteer completes part A, the nurse does part D, and the physician does part C. And if we have a nutritionist available, they always do part B. But if there is no nutritionist, no one does part B. And so in this manner, the system always knows the workflow which needs to be completed and the resources available on which to divide and allocate the workflow. And again, because we're using the example of a questionnaire, the workflow is the questionnaire, and the resources are the different clinicians to complete that. But you could imagine a more advanced version of dynamic task shifting, and that's why I use the term dynamic. For instance, if the system realized that the pharmacist was having a backlog build up of patients waiting to see them, perhaps the system would know that the backlog is developing at the pharmacist and therefore shift more questions to be given to the clinic nurse to complete if the nurse is seen before the patient gets to the pharmacist in order to offload the pharmacist's work burden. Of course, those steps or those questions would have to be coded as interchangeable between pharmacist and nurse, and the default would be to be in pharmacist, but if the pharmacist can't do it, it could also go to the nurse. And in theory, you could build the system so that if the pharmacist and the nurse are both super backed up, and they're the rate-limiting step in the clinic workflow, and the physician has nothing to do, that you could actually shift more questions into the physician encounter in real time to rebalance the load in the system, kind of like the way you would balance server loads. And then we move now into level 4. And level 4 is what we want to get to. And this is real-time multi-workflow threading. Let me explain. The more common issue is that a patient doesn't come in just to the hypertension clinic, but a patient might come in and they have both a diabetes and they have hypertension. Now, diabetes has a pre-built workflow, and hypertension has a pre-built workflow. But you don't want to have to complete each of these workflows independent of each other. What you want to do is to be able to have the system automatically in real-time thread that diabetes and hypertension workflows together into one single workflow, and then using the previous level of level 3 of real-time load balancing to take that one integrated diabetes hypertension workflow and divide out the work as required among the different people available in the clinic based on resources available. And so the key thing here is that when the system integrates these workflows, questions which are redundant between the workflows, if we're using the example of question, those redundant steps are removed, and then the steps which are integrated are actually threaded in a semi-reasonable manner. For instance, the blood pressure for the hypertension workflow should be placed in close proximity to the fingerstick glucose from the diabetes workflow. So when the nurse receives these two items from the two separate workflows, that in the new patient's custom workflow, they're in close proximity because the patient would be doing this part of the exam, the nurse would be doing this part of the exam at the same time. In a similar way, if the clinician was reviewing the hypertension medication side effects, part of the hypertension workflow, we want the part of the workflow from the diabetes workflow to then fall right after that hypertension medication review. Then we go into the diabetes medication review. Now, the way that this workflow integration could happen on a very basic level would be that the workflows are integrated right before the visit. And this could be based on information we have from a patient questionnaire, from a pre-selected set of options that the clinician had triaged before the encounter, or perhaps the clinician actually had figured out what workflows they want to go through at the next appointment when the patient was in their previous appointment. So that's the basic version. But what we really want to get, and this is why it's called real-time multi-workflow threading, is we need to be able to throw in new workflows into the existing custom workflow for the patient. So example, the patient is currently in step 3 of a diabetes hypertension workflow. And let's say that step 3 is the clinician appointment with the physician. If the physician, through discussions, finds the patient is having severe arthralgias, we want to then take the arthralgia workflow and automatically thread that in real time in the appointment into the existing workflow. And so there's two things that can happen. We can either integrate the workflow so that all of the entire workflow is only a feed-forward model, is only a forward model, meaning that if, let's say, the patient saw the nurse before they saw the clinician, that the clinician would then also do the parts of the workflow that the nurse would do. Therefore, the patient doesn't have to go back and restart the encounter, if that makes sense. So if we had an encounter where we had nurse, doctor, pharmacist, and we've now added arthralgias, we could do it two ways. We could either have the arthralgia workflow integrate just from the physician to the pharmacist, and therefore it's better for the patient, they don't have to go back to the start, or the workflow could actually divide that work to the nurse, to the clinician, the physician, and the pharmacist. And perhaps additional algorithms and automation could be built in based off of burden of different users in the clinic, based off the necessity and the amount of information to collect at different workflow steps. But you get the idea. Now, we need a dynamic system that can respond to this in real time. And now that we've got these three layers built out very elementary, we have the basic layer of separate workflows, which is how we operate on paper. We have the level of task shifting, where one workflow can be split among multiple users. Then we have level 3, where we have dynamic task shifting, where that workflow can be split among multiple users based off of who's in the clinic, when, and how busy people are. And then we have level 4, where not only are we able to balance workflows among multiple users, but we can also thread multiple workflows together, both before we start a workflow cascade and in real time while the cascade is going on. And that's just the beginning, right? You could imagine far more ways to do this more complex. For instance, when we were talking about steps and workflows, we were really just talking about questionnaires. But imagine that one step is lab results. Well, you could indicate in a workflow that the workflow should only start when all the components are required for that workflow, meaning that don't book the appointment for a patient in the appointment booking workflow until we have the MRI brain. And you can then set alerts so that if the MRI brain, hasn't been filed or it hasn't been reported within 2 weeks period of time, that then you should essentially receive an alarm that you haven't been able to book this workflow. And so in a similar manner, you could have it so that if a patient was in a clinic and they had to get blood work before they could go get their chemotherapy, that you shouldn't start a certain part of that in-clinic appointment until the patient's chemotherapy results are back. And if your system was fully integrated, it would realize that if the results were delayed, that those results probably needed to be prioritized on the lab information system, and so they could run that result quicker in order to expedite the clinic workflow in the other part of the hospital. Another example is using workflow length, or the anticipated workflow length, as a way to do system timing. So if you're trying to figure out the anticipated timing of how long a patient encounter may have for a new patient who has a new diagnosis of rheumatoid arthritis, and they're also being seen for follow-up hypertension, using this ability to thread workflows together, you could estimate perhaps approximately how long you may need. And then based on the resources available in clinic that day, you could also figure out whether how that balances. And then similarly, thinking about advanced load balancing, we talked about load balancing of moving questions in a clinic questionnaire from one user to another. But imagine if, again, the system's integrated properly, as some places have tried to do, that you load balance steps such as the lab or imaging or reception, so that the workflow is not just a patient inside of a clinic having a questionnaire administered, but the workflow is a patient going through the emergency department, and we route them to the lab or to the reception or to the imaging based off of relative wait lists. And of course, you can imagine adding far more levels of advanced clinical decision support that ultimately would replace steps within the workflow with an algorithm, and therefore speed that up, increase the efficiency of it. Just one last footnote I wanted to talk on very briefly on this issue of data provisioning. And this is more just a series of questions and concerns rather than an actual answer. When we think about data provisioning, we have a question of how is data signed off when it feeds through multiple users? For instance, if a community health volunteer completes an intake form and this information is fed into the physician form, who is responsible for the final version of the information? When it populates the physician form and they sign off on it, does it mean then that the physician is responsible for the validity of it? In some cases, this fed forward information is very crucial. The physician's actually rechecked it with the patient and it is true. In other cases, the fed forward information, it may be of absolutely no clinical utility and the physician didn't even read it. And so we have this issue of downstream data and users signing off on it when it falls into their auto-populated form. I wrote about this in a previous blog post entitled Manage Auto-Populated EHR Data Separately, which you may want to address. One of the other issues, though, is when information travels downstream, the question is, how do we visually represent this? Do we just represent the last user who corrected a data field? Or if a particular data field has been entered by user 1, gets corrected to a different value in user 2, and then it gets corrected by a third user in user 3, do we display all 3 answers in visual summaries? Do we display just the last one? Do we display the last 2? Do we display the most frequent ones? How do we actually know what's the truth here? And then secondly, how do we determine when someone comes in and tries to resolve these conflicts and actually say this is the truth? And then furthermore, how do we tag this metadata so that when we put machine learning algorithms on top of it, that we actually know what is the true data that the system should be analyzing versus previously entered but incorrect versions of the data? Anyway, I feel this is more administrative and workflow problems than actual technical problems, and therefore that means that this should be reasonably straightforward, simple to figure out if some people get in a room around a table. Anyway, I hope that this was a bit helpful in thinking about some different ways to think about workflow complexity. The next presentation will be discussing workspaces, which takes the concept of workflows one further in this idea of atomic design. Thank you.